Good afternoon, and thank you very much. I would like to start by thanking the research cell for giving me the opportunity to be, if I may say that, inaugural Professor SR Naik Award lecturer this year. Well, for my young friends in the audience and others who may not have known Professor SR Naik and who may not be aware of what this award is, let me inform you. The Professor SR Naik Award is given away by the Institute every year in honor of Professor Subhash R. Naik, who was the first head of Department of Gastroenterology at SGPGI. He also held the positions of Dean and Acting Director for some time. He was indeed an eminent scholar, eminent teacher, researcher, and above all, I feel a great influencer. He has made immense influence, or he has shaped a number of careers, not just of gastroenterologists, but all kind of specialists in this institute. And many things that we do 2016 to 20, mostly relating as less is indeed more. We do not need to subject patients with breast cancer to extensive treatment to achieve cure. Even with lesser treatment, more convenient treatment, less morbid treatment, we can achieve the same goal in majority. I'm sorry for this interruption, but while the projection comes up again, let me acknowledge the contribution of all my collaborators. This work that I'm going to present to you is indeed the work of an entire team, a multi-departmental, multidisciplinary team. And specifically, I would like to acknowledge the contributions made by my senior colleague and my mentor, Professor Sanjay Gambhir from Department of Nuclear Medicine. Primarily, I'll be addressing the issue of sentinel lymph node biopsy, and it was the team of surgeons and physicians or nuclear medicine physicians led by Professor Gambhir in starting 1999, which started this work. So how is breast cancer treated today? Of course, in terms of treatment, surgery remains the mainstay, and breast cancer surgery addresses both the tumor in the primary, that is the breast, as well as the lymph nodal metastasis to axilla. Breast cancers are epithelial cancers, and the first way that they spread is by lymphatics to the axillary nodes. And so we have to address the axilla in some way. Over the years, we have progressively minimalized the treatment or surgery of breast cancer. And indeed today, less is more. And I'll be focusing on how less is more in context of axillary treatment of breast cancer. And in a way, what I would like to focus is how we have been able to evolve a low-cost or frugal sentinel lymph node biopsy technique in our institute over the years. And these are the three papers or three studies which have been published in the recent 5 years, which I'll be focusing on, or which I'll be discussing a little bit on in details. So this is the list of collaborators. And as I said, besides my friends, besides Professor Sanjay Gambhir, I must also mention Professor Sevatkar, unfortunately he's no more, and others in the Department of Nuclear Medicine, the faculty members in departments of pathology and radiation oncology, and in my own departments, including the residents and research scholars. Well, breast cancer is the commonest cancer affecting women globally, as also in our country. And while we continue to treat a lot of women with locally advanced and advanced cancers, but over the recent 2 decades, we now have a fair number of early stage breast cancer patients too. And that has brought us to a kind of a crossroads. While we continue to dabble with all the problems with advanced cancers, simultaneously, we are expected to deliver the world-class treatment for these early stage cancers. And this world-class treatments come at a cost, not just economic cost, but other costs as well. And our country's health system and the patient's resources are not sufficient to meet those costs. And that leads us to a gross mismatch between the ground realities and the aspirations of our society. So that certainly requires a bit of innovation from the medical fraternity to provide high quality contemporary treatment strategies to our patients without the high cost that is involved with these more contemporary and high quality treatments. And not just we need to institute those, we have to provide the scientific community with sufficient data to validate the applicability of these innovative low-cost strategies. And that has been the focus of my research over the last 2 decades. A number of innovations have been introduced by the SGPGI Breast Health Program. Some of these are listed here, but what I'm going to focus is on the low-cost sentinel lymph node biopsy, and specifically the use of low-cost radiotracers and low-cost methylene blue dye and the fluorescein-guided sentinel lymph node biopsy. Well, axillary surgery is an essential component of breast cancer surgery because it gives us the vital staging information, which provides us with the prognosis of the patient, and it helps us defining or deciding the adjuvant treatment the patient would require. It also adds to the loco-regional control of disease, but it comes with some bit of morbidity. So an approach with horses for courses is the right approach here too. And depending on the initial stage at presentation, we decide what kind of treatment strategies are required for that individual patient. And in context of axillary stage, patients who do not have any palpable lymph nodes in the axilla or enlarged lymph nodes identified on preoperative imaging, these are what we call as the N0 patients. And these are the patients who benefit from the strategy of sentinel lymph node biopsy and avoidance of axillary dissection. So sentinel lymph node biopsy is the current gold standard for determining the nodal stage in patients who have clinically N0 axilla. And this is associated with significantly lesser complications or morbidity as compared to the old gold standard that was the standard axillary dissection. It offers excellent local control or regional control without extensive dissection. And in various extensive and very high quality studies, it has been proven that it does not result in any inferior survival when compared to the older axillary dissection. And this is the kind of complete dissection we end up with in patients who have metastatic nodes. And this is this old gold standard axillary dissection is still contemporary in patients who have multiple metastatic nodes. However, this comes with a bit of morbidity, both early and delayed. And more importantly, roughly 2/3 of all patients that we treat actually do not benefit at all from axillary dissection. So the alternative is sentinel lymph node biopsy, and this procedure is based on the orderly axillary the lymphatic drainage system of the breast. The lymphatics from the breast, they drain into various lymph nodes in the axilla. And by detecting those particular few lymph nodes or one or two lymph nodes, which are at greatest probability of receiving lymphatics from the breast. And so these are the sentinel or sentry nodes of the axilla. And selectively removing them, biopsying them, and seeing if there's indeed any spread of the cancer, we can select patients who are candidates for axillary dissection and avoid axillary dissection in the rest. So this is the kind of strategy we use in patients who have clinically nodes negative axilla. We detect the sentinel node, remove it selectively with minimal dissection, subject it to either rapid frozen section histology or otherwise conventional histology. If indeed there's any metastatic deposit in those sentinel nodes, we go ahead and do a completion axillary dissection. If, however, the sentinel lymph node does not have any metastatic deposits, we can avoid axillary dissection and so give the benefit of avoidance of morbidity. And this is possible, as I said, in more than 2/3 of all patients. For doing the sentinel lymph node biopsy, you have to use certain lymphophilic dyes or tracers which are picked up by the lymphatics and concentrated, they're selectively taken into these sentinel nodes. And there are two different kinds of dyes that we commonly use. One is a color dye, and usually we use blue dyes. Methylene blue is the one which we use commonly, and the other is a radiopharmaceutical. And the radiopharmaceutical helps us detect a hot node, a node which has concentrated the radiopharmaceutical using a handheld gamma probe, the kind that you see in these pictures. And the gamma probe helps us plot the roadmap to the sentinel node. And then we try and locate a blue and hot or a blue or hot lymph node, take it out selectively, subject it to histology, and as I said, we do the rest of the decide rest of the treatment strategies accordingly. For us, this whole journey of sentinel lymph node biopsies started sometime in mid-1999, a few years after the first extensive report of sentinel lymph node biopsy was reported from Italy. Initially, we had to beg and borrow and for both the dyes and the gamma probe and everything. These were not available. Even if we had resources, we could not have bought it in India because these are not marketed in India. And that led us to it compelled us to innovate, to use in-house produced low-cost methylene blue dye and technetium antimony colloid, which was produced by the nuclear pharmacy of our institute. To give you a comparison of the costs, the commercial dyes at that time, if it was available, it would have costed us, say, $40 per case, the radiopharmaceutical, whereas what we were using was technetium antimony colloid, which costed less than 100 rupees per case. Similarly, the lymphazurin dye, the standard blue dye that was not available, had it been available, it would have costed $31 per patient. Whereas we used analytical grade methylene blue, which we sterilized after filtration, and the cost was less than 10 rupees. So there was no doubt that we were saving money for the patients and for our system. And in our first validation study, which we conducted between 2000 and 2003, we reported 120 patients with a very healthy sentinel lymph node identification rate and an acceptable false negative rate of 2.1%. And by the way, the gold standard or acceptable false negative rates for sentinel lymph node biopsies globally is less than 10%. So if in hands of any individual surgeon or a team, the false negative rates are in excess of 10%, it means that that team should not practice sentinel lymph node biopsy. Similarly, if we fail to identify sentinel lymph nodes in less than 90% of patients, then we should perhaps not be practicing sentinel lymph node biopsy. From that yardstick, we were good enough to practice this. Much more recently, well, we've been practicing those strategies over years, but often we would face questions about the scientific validity of these practices. And the scientific validity would have come only in the way of a randomized controlled trial of comparing the commercial dyes used versus our in-house produced low-cost dyes. And as one of those studies, which was the research project for MCH of one of my students and was supported by an intramural grant, we compared in a randomized fashion the results of an in-house produced low-cost pharmaceutical versus the commercial radiopharmaceutical for sentinel lymph node biopsy in early stage breast cancer patients undergoing primary surgery. So this comparison was done between the commercial technetium sulfur colloid, which we bought from Bark. And by the way, Bark products are much cheaper, much less expensive compared to the, say, other radiopharmaceuticals available. And we compared with the results of technetium antimony colloid, which was produced in-house by the Department of Nuclear Medicine. The three key indices that we focused on was the intraoperative sentinel lymph node identification rate, the false negative rate, and the cost incurred in the two arms. And in the prospective randomized way, 78 patients were divided into group 1, which was technetium antimony colloid group, and group 2 of sulfur colloid patients. And methylene blue was used as a standard in either of the arms. Irrespective of the sentinel lymph node histology, we went ahead and did a complete axillary dissection so that we could validate and arrive at the false negative rates. And the comparison of the costs were that in patients who received technetium antimony colloid, the mean cost was less than $1 compared to approximately $13.2 in sulfur colloid group. The results are tabulated here, and you can straight away focus on almost identical sentinel lymph node identification rate and false negative rates. So from this study, we concluded that the accuracy of sentinel lymph node biopsy in early breast cancer patients undergoing primary surgery was comparable when we used either the commercial technetium sulfur colloid or the in-house produced low-cost technetium antimony colloid. So, and then while the in-house produced dye was 15 times more economical. Well, primary surgery is a desirable thing to do, but more and more we are now shifting to post-neoadjuvant chemotherapy surgery, both in locally advanced cancer patients as well as selected early stage cancers, especially in certain biological subtypes like triple negative and HER2 enriched types. Post-neoadjuvant chemotherapy sentinel lymph node biopsy comes with some bit extra concerns. And these concerns emerge out of the fact that systemic treatment induces some bit of fibrosis and perhaps occlusion of the afferent lymphatics of the sentinel nodes, as you can see here in this picture. And so we had to address this issue. And then, by the way, being, practicing in a developing country, we tend to, or we have to treat a larger proportion of locally advanced or stage 3 cancers compared to Western countries. So it is indeed a question that we have to answer. So initial research that we conducted was to validate post-neoadjuvant chemotherapy results in patients undergoing post-NSCT sentinel lymph node biopsy, and this was published in Cancer Research in 2016. But a more systematic comparative study we conducted in between 2016 and 18, where we compared the results of primary sentinel lymph node biopsy, which means before we institute any systemic treatment, we did sentinel lymph node biopsy in a set of patients, and we compared those results with patients who had undergone neoadjuvant chemotherapy. And this was a study exclusive to stage 3 cancers. And the reason I am emphasizing this is because this is the kind of patients that we have to cater to large in a large proportion. And these are the kind of studies we do not expect to come from Western countries. So in a non-randomized prospective study, we had 50 patients who underwent primary sentinel lymph node biopsy, and the rest 70 underwent post-NSCT sentinel lymph node biopsy, and we compared the sentinel lymph node identification and the false negative rates between the two groups. Comparing the two groups, the sentinel lymph node identification rate was awfully short of the expectation of 90% in patients who had undergone neoadjuvant chemotherapy. So this was certainly not acceptable. But patients who had undergone primary sentinel lymph node biopsy, the sentinel lymph node identification was good enough at 94%. Looking at the subgroups, such patients who had stage 3A disease, which means they had T3 and N0 or at worst N1 stage to begin with, the sentinel lymph node identification rate was quite good, even when the surgery was post NACT. However, in patients who had T4B, which is a stage when the patient has skin involvement because of breast cancer, or N2A stage, which is when there are matted nodes in the axilla, these are the kind of patients where we found, irrespective whether the surgery is primary or post NACT, the identification rates are dismal. Similarly, the false negative rates in patients who underwent post neoadjuvant chemotherapy sentinel lymph node biopsy, they were unacceptably high at 13.5%. And yet again, we found in patients with stage 3A disease, perhaps it is okay to do sentinel lymph node biopsy, either primary or post NACT, but it is certainly not acceptable for patients who have stage 3B disease. So we concluded from this study that sentinel lymph node identification rate is unacceptably low, and the false negative rates are unacceptably high in patients who have T4B or N2A disease. And this has led to quite a bit of acceptance of this strategy. And globally now we see a number of publications quoting these studies, these results, and also making similar inferences. And finally, I would in very short describe this another, I would say, path-breaking kind of study. So far, the two studies that I discussed involved use of radiopharmaceutical and a gamma probe. And I don't need to tell you that how few centers in our country and perhaps across the world would have the luxury of having a nuclear medicine facility. And the cost of gamma probe continues to be considerable. So if there could be a strategy of doing sentinel lymph node biopsy without use of gamma probe and radiopharmaceutical at all, it would be very helpful. It would help wider usage of this strategy. And this study that we conducted was primarily aimed at that. This was again the MCS project of one of my students, and it was supported by an ICMR grant to her. And here, instead of using, in this study, we compared the sentinel lymph node identification rates and false negative rates using fluorescein, which is a low-cost fluorescent dye, and a very low-cost blue LED light. Of course, there's another fluorescent dye available, which is ICG. Unfortunately, for using that, one needs to use a very expensive near-infrared detection system, a CCD device, which is multi-crores or at least close to a crore, whereas what we used was a much cheaper fluorescein dye. The study was presented by the student in World Congress of Surgery and was awarded the best poster. I'm sorry for this bit of jumbled up slide, but this was a prospective cross-sectional non-randomized validation study in 65 patients as per the sample size calculation. And we compared the sentinel lymph node identification rates and the false negative rates using the low-cost fluorescein coupled with blue LED light. The fluorescein cost ₹90, and the blue LED light that we bought was for 250 rupees and can be used multiple times. Compared that with radiocolloid and handheld gamma probe, either alone or in combination with methylene blue, and we found that the sentinel lymph node identification rate and the false negative rates were very comparable between use of fluorescein and radiopharmaceutical. And as a result, we could conclude that sentinel lymph node identification, use of fluorescein, low-cost fluorescein, is as good as radiocolloid. Perhaps fluorescein can now replace radiopharmaceutical for sentinel lymph node biopsies, thus making sentinel lymph node biopsies acceptable or available widely. So in summary, what I have talked about is how less is more in context of axillary surgery of breast cancer, And what has been the impact of these low-cost innovations and practices at SGPGI? We now have a routine application of sentinel lymph node biopsy in early breast cancer patient and selected large operable and locally advanced breast cancer patients undergoing primary or post-neoadjuvant chemotherapy surgery. We are able to do a single stage complete treatment for majority of our patients without adding any substantial cost to their treatment. And this has also helped us train quite a few numbers of surgeons, nuclear medicine teams, and this has led to a wider applicability or acceptability. And I can't help but remember when we started talking about sentinel lymph node biopsies in 2000, 2001, I used to be shot down or in various conferences and workshops when I demonstrated these in, say, like a conference of Indian Association of Surgical Oncology, and almost the entire house would say, "Oh, this is not for India." And today, almost every center worth its salt in the country is doing sentinel lymph node biopsy. So it's entirely because of this team of very active collaborators, very able collaborators, that we have been able to establish the utility of sentinel lymph node biopsy. And I once again thank the research cell